Hi everyone. So we're gonna go ahead and get started. This is Dr. Omofoy.
Yeah, that's close enough.
Okay. And he's a new neurosurgeon who specializes in criminal neurosurgery and brain tumors. He graduated with a BS in biomedical engineering from UNC Chapel Hill and obtained a MS in mechanical engineering from Columbia University in New York. So that's very impressive. And so everyone, for attendance purposes, please make sure you're interacting in the chat and sending any questions you have. And you can take it away by talking about yourself and your career.
Okay, great. Yeah, so like you said, I started my undergraduate degree at University of North Carolina in Chapel Hill. That was after immigrating to the United States with my family at the age of 16 from Nigeria in West Africa. And growing up, I was always interested in medicine. I always wanted to be a doctor growing up, and that was due to interest in science and learning about the human body. And in undergrad I took anatomy course and really loved the anatomy portion of my biology classes, and dissection and all of that, learning all the different parts of the body. And that was sort of the beginning of my interest in medicine. But I also liked engineering at the same time. I like math, I like physics, and doing biomedical engineering was a good way to combine those two interests. And that was how I chose my major in college. And because I was doing both engineering and also taking my pre-med prerequisites, it was tough balancing my time. Usually before you go into medical school, you have to take an MCAT, which is the medical, college admission test, to get into medical school. And most people take that between around their junior year of college. And so, because I was taking some of my classes to make up all my classes that I needed to do to graduate on time, I ended up taking the MCAT after I graduated college, the summer after finishing college. And I knew ahead of time I was going to have that year gap before medical school. So I decided to do a master's in mechanical engineering at Columbia, because they had a advanced robotics lab up there, and I was interested in surgical robotics. And that was why I did that. And that was a good way to continue my interest. It was also my backup plan in case I didn't get into medical school. I would pursue that field. And I was fortunate to get into medical school, decided to come back closer to my family in North Carolina for med school. And came back to UNC and Chapel Hill for medical school. And I got interested in neurosurgery while I was there. And after that, then you do a residency, which is a 7-year training to become a neurosurgeon. And so I completed that at recently at the University of California in Davis. And I decided to do an additional year of training, which is called fellowship after residency, if you want to subspecialized. So I'm a neurosurgeon who's subspecialized in neurosurgical oncology, meaning brain tumors, essentially. So that's sort of the quick, summary of my training so far.
So what I know surgery is like a really big field. There's so many different things in the body to operate around. So
Yeah,
what made you choose like neurosurgery?
yeah, good question. So going into medical school, I knew I was probably going to do something surgery related, just
Mm-hmm.
because I like working with my hands. Coming from an engineering background, to like fixing things, and so I sort of leaned to that specialty. But yeah, you're correct. There are multiple different subspecialties within surgery. You can choose to be a pediatric surgeon who just focuses on kids. Can choose to be a general surgeon who focuses on any sort of abdominal organs, some of the endocrine organs, colon. There's sort of different branches between general surgery as well. You can do orthopedic surgery, so anything in the bones, fractures, joints, things like that. You could do, OB/GYN is considered a surgical subspecialty, doing C-sections and diseases, cancers of the uterus, things like that. There's plastic surgery. So there's multiple different surgical fields. But my interest in neurosurgery sort of began my first year of medical school, I was part of a group called the Surgery Interest Group. And so this is a group of medical students who are interested in some kind of surgery, but they're not quite sure yet. And so I was a member my first year of medical school, and my second year I was actually co-president of that group. And what we would do in that group is have sessions like this, where we have a surgeon come talk to us, and we had a neurosurgeon come talk to us when I was a first year medical student, and he talked about something called deep brain stimulation, which is where you implant electrodes into the brain to help a part of the brain sort of work. And most commonly, this is done for Parkinson's disease. So Parkinson's disease, is a type of disease in the brain. It's a degenerative disease, and so people who have it, they have problems with tremors. And what tremors means is that shaking of a part of the body. So most commonly, it's usually in the hands. Usually, patients will start noticing their hands kind of shaking when it's at rest. And sometimes that can evolve from one side to the other side. And if you get to the point where they're not unable to eat, they can't hold a spoon to their mouth just because their hand is shaking. They can't hold a cup because the drink will spill. And famous example of that is Michael J. Fox, who is a celebrity from the Back to the Future series, and he's a big advocate for Parkinson's disease. So usually, if a patient has Parkinson's disease, they try them on different medications. Sometimes the medications stop working, they start getting side effects. And if it gets to that point, then they can undergo surgery. And so what the surgery entails is that, you drill a small hole in the skull and you put an electrode into the brain. The surgery is actually done while the patient is awake. And they keep the patient awake so you can test their movement. And, so we had the neurosurgeon talk to us about that. And I thought it was really fascinating, surgery. I thought it was very exciting. It was a combination of both engineering and medicine for me, which was my, background and my interest in using engineering applications like, electrodes, microelectrodes to control brain function. So after the talk, I was really fascinated by the presentation, and I went up to him and I told him, "Hey, I'm really interested in this. How can I shadow you?" So I shadowed him in the operating room during the winter break of my first year of medical school, and saw a patient who had that Parkinson's disease. And while I was in the surgery with him, watching the case, they turned on the device after they've implanted it to test it, and his tremors just completely stopped. And they turned the device off, and his tremors came back, and it was like switching on and off a light switch. And that I thought was almost like magic to me. And that was the beginning of my interest in neurosurgery. So from there, I learned a lot more about neurosurgery, and I actually took a year off during my medical school, between my third and fourth year of medical school, to do research with the neurosurgery department. And and that's sort of how I got interested in it. And the way it works is you have to apply after your fourth year of medical school, or during your fourth year of medical school, to a specialty that you decided to follow. And then there's something called a match, where you interview at a bunch of hospitals, and then a computer sort of match up your rank. You rank all the hospitals you interview at, all the hospitals rank all the medical students they interviewed, and then there's a match process that happens, and that's how you find out if you're matched or not, and where you're going to end up to train as a resident.
So what is like how you saw the Parkinson's through surgery? What is the success rate of the surgery? Most likely that it come out beneficial to the patient, or the
Yeah,
other way around.
yeah, no, it's very successful. Which is why we do it. If it's placed correctly in the right location,
Mm-hmm.
I would say it's greater than 90% success rate. Obviously there are risks to any kind of surgery that we do. The most common things that we see in terms of risks of surgery are bleeding and infection. So there can be bleeding during the surgery. There can be an infection. If there's a bleeding in the brain, obviously that's a stroke, where it affects the function of one part of the brain. The risk of having a stroke from the deep brain stimulation procedure is very small. It's less than 3%. Same with infections, probably it's less than 5% risk. But the thing with infection is, if there's an infection that happens in the brain, unfortunately, you kind of have to go back in and take the device out because it's a foreign device.
Mm-hmm.
And so the other risk are things like seizures. So um, seizures can happen anytime you're messing with the brain, and it's just because there's an abnormal electrical signal in the brain, and it causes people to have convulsions, shaken
Mm-hmm.
episodes, losing consciousness, things like that. And but if you add up all the risks for a procedure like deep brain stimulation, it's probably about 10%. So it's a pretty successful surgery.
Mm-hmm. So what type of different equipment do you use for this surgery and compared to like other specific surgeries for like curing it, try to cure disease or take out
Yeah.
tumor? Mm-hmm.
Yeah, so in neurosurgery in general, it's a very technology heavy specialty, as most such surgical subspecialties are. And with each passing year, there are sort of newer technologies that come in the market, and so we use a lot of equipment in the operating room. So one of the big things that we use is a microscope. And
Mm-hmm.
so when most people in high school think of a microscope, they think of a smaller microscope where you're looking through, looking at
Mm-hmm.
the cells and things like that. But we have a large, it's a big microscope,
Mm-hmm.
sort of like almost like the size of a fridge, for example,
Mm-hmm.
that we use to do surgery. And the reason why we use that is because everything in the brain has very smaller structure. So there are tiny blood vessels in the brain. There are tiny nerves at the base of the brain called the cranial nerves that you have to be careful about if you're doing surgery. And so
Mm-hmm.
when you've done a craniotomy, you've taken the bone, the cranium, the skull, you've taken it off, and you're looking at the brain. Usually at that point, there's a covering of the brain that's called the dura that we open
Mm-hmm.
up to get to the brain. And at that point, we bring the microscope in. And so it magnifies the field. And so we can look through the microscope and do surgery through the microscope. That way you're
Mm-hmm.
avoiding, damaging any blood vessels, any important
Mm-hmm.
nerves. So we use that a lot, especially for tumor surgeries. Pretty much
Mm-hmm.
all the cases we use microscope for. And then we also use a navigation system. So there's the navigation system. It's kind of like a GPS system that helps you guide your surgery. So, for example, if you're taking out a tumor, and this tumor is it's not very different from normal brain. So there are certain tumors like something called a low-grade glioma. It's a type of tumor that grows from the brain, but it's not very different. It doesn't look that much different from normal brain. So sometimes it's difficult to know what's tumor, what's normal brain. And so if
Mm-hmm.
you use this navigation system, what it does is it helps you pinpoint exactly where you are in the brain on a patient scan. So before surgery, a patient will get an MRI. MRI stands for magnetic resonance imaging. So it's a high definition scan of the patient's brain. And, so while you're doing the surgery, you can, after you do something called a registration where you register the patient's skull to the MRI. So you basically track all across their head with a probe. So you point one location and the navigation system figures out where that is on the MRI. So after
Mm-hmm.
you've done with the registration, so if you point to this forehead, for example, and you look on the scan, you see exactly where you are on that patient's MRI. So while you're doing the surgery, you use that to guide your surgery. And so you
Mm-hmm.
know exactly where you are in the brain as you're looking at the scan. If it's a small tumor, you can use the navigation system to find the tumor. And so we use a lot of that. And then for things like sometimes if you do a biopsy, there are different technology that we use to do a biopsy in the brain that helps guide that surgery. Yeah.
So how long does it usually take for an oncologist surgery to remove like a tumor or something?
Yeah, good question. It depends. So it depends on the type of tumor. It depends on the size of the tumor. It depends on the
Mm-hmm.
location of the tumor, and so that's really what determines the length of surgery. I would say on average, it probably takes about 4 hours, 4 or 5 hours to
Mm-hmm.
take it out if it's just an average size tumor. But
Mm-hmm.
if it's if it's a tumor that's at the a difficult location in the brain, and you have to be very careful to avoid some important nerves. Then it's going to take a longer time. If it's a tumor that's wrapped around an important nerve, for example, I would say the longest surgeries we do in neurosurgery. There's a type of tumor that's called a vestibular schwannoma, it's a tumor that grows from nerves. It's the balance nerves that help you balance the vestibular nerve. It's the eighth cranial nerve. It's actually called the vestibulocochlear nerve because it's the same nerve that helps you hear and also maintain your balance. And there's a tumor that grows from it, and it tends to wrap around the facial nerve. That's a nerve that supplies, controlling your face, so moving your face. And so, that tumor tends to wrap around that facial nerve, and sometimes you have to dissect very slowly around the nerve so you don't cause someone to have a facial paralysis. And sometimes the surgery may take up to 24 hours. I've seen this. It's the longest I've seen where usually it's multiple surgeons doing the surgery. Usually you have an ear, nose, and throat surgeon and a neurosurgeon doing it together. Yeah, but relatively most surgeries, 4 or 5 hours.
Mhm. Okay. So then, like the patient would be on anesthesia the whole time if it was like
Yep.
a
Yeah, correct.
so,
Yeah, pretty much all this surgery, most of the surgeries we do with general anesthesia. There are some surgeries that we do with local anesthesia. Maybe not just local anesthesia. We sometimes we give them what's called a conscious sedation, where they're kept awake, but you can sedate them a little bit. And so there's some type of tumors that we do an awake craniotomy, awake surgery, because you want to test their function. So if there's a tumor that's growing from the area of the brain that controls speech, for example, most people that's on the left side of the brain, and you want to test their speech as you're resecting the tumor to make sure you're just resecting the tumor, but you don't cause them to have a speech deficit. You can keep those patients awake during the surgery. You give them numbing medications all around their scalp, and usually they keep them a little bit sedated with some sedation through the IV. And for the part where you're making an incision in the scalp, you're taking the bone off, and then once all of that is done, you're ready to start taking tumor, then they wake the patient up. They stop the IV sedation. And at that point, you can ask the patient to do things like, say the ABCs. They can name, sometimes we have little flashcards that we give them to name some words. And so they're doing all of that while you're resecting the tumor so you're able to do the surgery safely.
So what other specialists needs to be in the room at the same time you're conducting surgery, and like nurses and technicians?
Yeah.
What is
Yeah, there's usually a lot of people in the room. So in most, hospitals where, you have some trainees as well. Sometimes you have trainees in the room, like at academic hospitals that's affiliated, with a university, where you have residents who are training to become attending neurosurgeons. There will be a neurosurgeon who's attending, who's sort of in charge of the case. There will be a neurosurgery resident who's someone who's already graduated medical school, but now they're training to do neurosurgery specifically. There's usually a scrub tech, and what a scrub tech is a technician who knows all the equipment, and they hand you all the equipment you need during the surgery. They connect all the machines that you need to your scalpel. We use a lot of equipment, suction, all the different types of equipment that you're going to need. A scrub tech hands that to you during the surgery. And there's usually a nurse who's circulating. So a nurse who's in the room, they help if you need something to be grabbed from one place. They give it to you. They're also taking notes during the surgery on how the surgery is going. There's an anesthesiologist in the room, and the role of the anesthesiologist is to get the patient to sleep. They wake the patient back up from surgery, from sleep after surgery, and throughout the surgery, they're monitoring how the patient is doing, all of their labs, and making sure they're breathing okay, and all of that. And sometimes as an anesthesia resident, if you're in a teaching hospital, sometimes there's what's called a CRNA. It's like an assistant to the anesthesiologist. They're sort of certified, registered nurse and anesthetist that help. And let's see, well, sometimes there are reps in the room. So reps usually they work for a certain company that has an equipment that's being used. So if we're using a microscope, sometimes there may be a representative from the company that makes the microscope. So if the microscope is not working, for example, they can fix it. Or if the navigation system is not working, they can fix that. So those are usually the basic amount of people. So sometimes there's a lot of people in the room, and then if you had a teaching facility, there could be medical students in the room who are watching, as well. And one of the other things we do in neurosurgery is something called neuro monitoring. So there's a way that you can monitor all the patient's sensation and their motor function during the surgery, where they put little electrodes into different muscles, and we can do some monitoring. So while you're doing the surgery, if something bad happens, the person that is doing the neuro monitoring can tell you, "Hey, I lost signals in the patient's left leg, for example." So okay, something weird happened there. And so there could be a neuro monitoring specialist in the room as well.
Cool. So we have kind of follow-up question. So after the surgery, what type of follow-ups do you need? Does the patient need to? Because obviously surgery is like a really big event in someone's life. So then, what type
Right.
of what's kind of the journey after the surgery, depending on whether it's like maybe a gynecological surgery or like a tumor or something like that.
Yeah. So for neurosurgical oncology, I'll talk about brain tumors, specifically. So usually after surgery, the patient will go to an ICU after, at least for one night.
Mm-hmm.
ICU is intensive care unit in the hospital where you have a nurse who's watching the patient very closely. They're monitoring them every hour, making sure they're doing okay. They're looking for any problems that could arise after surgery. For example, if you have bleeding in the brain, stroke after surgery, they can pick that up quickly. They're monitoring them as they're recovering from anesthesia. And usually if the patients are doing well, overnight in the ICU, then they go to a regular floor bed in the hospital. And at that point, they will work with some therapists. Usually there's a physical therapist who walk with them to make sure, get them up, walk them around, make sure their balance is okay. They're able to, move around with no problems, do things for themselves. There's an occupational therapist that makes sure they're able to do things like, brush their teeth and things that they will need to do at home. And usually after the physical therapists say they're clear to go home, then we discharge the patient home. And we want to make sure at that point, their pain is well controlled, they're able to eat, they're able to drink, urinate, do the basic functions when they go home. Sometimes patients need more help. They may need to go to a rehab facility if they have some kind of weakness after surgery. And they may need to go to rehab for like a week or two before they get stronger enough to go home. So that's usually the patient's course. And usually after about 2 weeks after the surgery, patient follows up because that's usually about the time it takes for their incision to heal. And sometimes we use sutures that needs to be taken out or staples in the scalp. So at that 2-week point, we take the sutures out, we take the staples out, make sure the incision looks okay, see how they're doing. And if there's any kind of results from the surgery, so if you take a brain tumor out, for example, at that 2-week mark, usually what happens is when you've taken the brain tumor out, you send it to a pathologist. So a pathologist is another specialty, a medical specialty that you basically learn how to diagnose diseases based on the cells makeup. So that tumor specimen goes to a pathologist. A pathologist will take a look at it under the microscope. They do different stains on it. Sometimes they look at the genetic profile of the tumor, the molecular characteristics of the tumor, and they can say, okay, we know this is this type of tumor. This is either a benign tumor, a malignant tumor. And once they've made that diagnosis, when the patient follows up in 2 weeks, we tell them, okay, this is what the results show, your pathology results show. This is the type of tumor that you have. If it's a malignant tumor, so in the brain, the most common one is called glioblastoma, which is a very rapidly growing tumor. If it's that type of tumor that's malignant, then the patient has to have chemotherapy and radiation. So usually after surgery, if they have a malignant diagnosis, then we send them to the medical oncologist, is another specialty, and the radiation oncologist. So then they put them on chemotherapy. They may need radiation. And then usually after that, it may follow up maybe 3 months. If it's a benign tumor, maybe you see the patient every year, make sure the tumor doesn't come back.
Okay, so that was very interesting. And I have one more question. So, sort of as the patient is dealing with recovery, what are some of the complications that you've seen?
Yeah, so just like we've talked about, like I
Mm-hmm.
said, bleeding and infection, that's sort of the most
Mm-hmm.
common complication. So if a patient
Mm-hmm.
has bleeding in the brain, they can have a stroke. And so if a patient has a stroke,
Mm-hmm.
that can affect their ability to function. If it's a stroke that affects their right arm, for example, they can have weakness. Very, very rarely, patients can have things like paralysis after surgery, but that's very rare. Usually, it's some kind of mild weakness, and usually it gets better with therapy. Seizures, is a risk with surgery or a complication, so to say. But if that happens, we just put them on medications to treat the seizures. Actually, most patients who have any kind of brain surgery, you put them on some what we call prophylactic seizure medication. So just to prevent any kind of seizures, you can put them on seizure medication for about a week, or some places do it up to 2 weeks to prevent any kind of seizures. So that can happen. There can be problems with incision if there's an infection. Patient may need to go on antibiotics, or they may need to have additional surgery where you go in, try to wash out the infection, which can happen. So those are sort of the most common risks.
So, I mean, as being like a doctor and a medical school and being a surgeon, I'm guessing you use a lot of like pharmacology and different fields sort of correlating to medicine. So I was
Mhm.
wondering what are some kind of skills that you really need to be a surgeon that people have to start developing in like medical school or even after high school that would really
Yeah.
help you go through the whole, process that's very grueling and challenging.
Yeah, I mean everything you can learn how to do, and it's a long training, and that's why neurosurgery is 7 years, is because there's a lot to learn, and there's a lot of skills you need to attain. Right after high school, if you're interested in medicine or in surgery in general, what I recommend is just going to a college that has a medical school affiliated with the university.
Mm-hmm.
And so, while you're in college, you can start getting involved with research,
Mm-hmm.
with the medical school that's affiliated with the
Mm-hmm.
university, and you can start, shadowing as well. So as an
Mm-hmm.
undergraduate, you can shadow physicians. That's a good way to get exposure to specifically be a surgeon. I mean, most other skills you need, you can get trained on how to do them. Obviously, if you're have a lot of dexterity with your hands, you like doing things with your hands, that's helpful.
Mm-hmm.
Some people are, you know, better with their hands than others, but most of it is a skill that you can learn as you go through your residency, and that's the job of the attending physician or the attending surgeon, is to learn and teach you the tips and tricks that you need. The most important thing is choosing a specialty that you love, you're interested in, that you're passionate about, and once you've made that decision and you're in the right field, everything should fall into place.
So, did you have any research that you did when you were medical school or even residency that you want to talk about, or
Yeah. I
Mhm.
did lots of research all throughout my different training. So as an undergraduate, I started working at a colon cancer research lab. During my freshman year of college, actually, I had to do it's called a federal work study program, where you have to, work for a little bit to get some money. So I did that kind of part time. I worked um, with a mentor who was actually very helpful in me getting into medical school and writing my letters of recommendation. And so I would do things like DNA sequencing, where you sequence, DNA from people who have had colonoscopies done, and whatever kind of polyps they take out from a colonoscopy. We look at it, look at what the genetic factors that cause them to have colon cancer, for example. And in medical school, like I said earlier, I took a year off to do neurosurgery research. So I did things like we worked on cadavers. So one of the procedures that we do in neurosurgery, we can actually go through the nose to do some procedures in the brain. So there's some type of tumors like pituitary tumors that you can go through the nose to do. So, but I was looking at, going through the nose to do other types of procedures like clipping aneurysms, for example. So we did some
Mhm.
dissections on cadavers to look at how is that possible to do, to try to kind of push the boundary of things we can do in neurosurgery. And then during residency, actually worked with the biomedical engineering department at UC Davis, and we were looking at ways, to look at brain tumors, to make diagnosis of brain tumors because usually, like I said before, if you take a tumor out, you
Mm-hmm.
can you take it to the pathologist. It takes about a week or two for the final results to come back. We're looking at a device using lasers, for example, to place a laser on top of the tumor, and that laser can reflect back, some light, and we analyze that light to look at the properties of the tumor to see if we can actually make a diagnosis in the operating room using a laser. So those are some examples of research I've done.
That's actually really cool. I would like to get involved in some kind of clinical research, like in my senior year or after high school, sort of to see if that's something I'm interested in. And I think it's also related to like, psychology um, and medicine and science and math. So I think that's something really cool about research.
Right, right.
So, what do you have any like advice that you would give to high schoolers who are interested in math and science who want to apply to these schools, but like what are some things to look out for, sort of being like a good candidate?
Yeah, I mean, obviously, the easiest thing is just make sure you're doing well in your classes. Currently, you're taking classes that are challenging you. You're taking honors classes, AP classes, where you're challenging yourself, because college is very different from high school. It's a lot more challenging, obviously, but it's a better atmosphere where you have sets of people who focused on the academics. Obviously, you have a lot of fun in college as well. But the
Mm-hmm.
main thing is just focusing on your classes in high school, getting good grades, obviously, on the SATs, PSATs, to get into a good college. But I think college. You want to make sure you go somewhere where you're comfortable, where you're gonna feel like there's a support system for you. Um,
Mm-hmm.
just because you want to have an area where you can grow in yourself and pursue your own interest.
Mm-hmm.
Where there's family support if you need that. And finding the right mentors is very, very, very critical. And once you identify an interest, the main thing is just to look for somebody who is doing what you're interested in doing, and having them be a mentor to kind of help you navigate the course, because it's difficult, particularly for people who are from underrepresented backgrounds or disadvantaged backgrounds who don't have a lot of avenues
Yeah.
uh, to seek mentorship, and so that's very vital. Those who have been through it, they can tell you, okay, this is what you do, this is what you don't do, this is how you write your personal statement, this is who you get letters of recommendation for, and this are the things that you need to do to get to the way you need to be.
Mhm. Okay, that's very helpful. So thank you for telling us that.
Yeah.
And more question. So what are some challenges that you face like every day as a surgeon, or something that surgeons have to go through every day that all the other specialities don't?
Yeah, it's a good question.
Mhm.
I guess the difference, between surgeons and other sort of medical subspecialties is obviously is that you're operating on patients. You're cutting patients open and trying to fix the problem that's there.
Mhm.
The gratifying aspect of that is patients come in, they have a problem, they have a weakness, and you can go in, you can fix the problem right away. So there's an instant gratification that happens with surgery. But at the same time, it can cause complications to happen, just like we've talked about. So one of the things that surgeons deal with, that maybe other specialties also deal with, but maybe in a different way, is in terms of if there's a complication that arises in a case, for example, dealing with that and knowing you've hurt somebody essentially, and sometimes that's difficult to get over. But
Mhm.
the thing about medicine is it's a lifelong learning process, and
Mhm.
you just have to um, you know learn from your mistakes. If you made a mistake during the surgery and caused a complication to happen, you just learn from it, try to make sure it doesn't happen again, and obviously try to carry those lessons that you've learned to the next patient that you treat. And so that's something that happens in medicine as just being able to deal with your own, human, behaviors, the fact that everybody's human, make mistakes, being able to learn from those experiences. It's something that in surgery, specifically, you kind of have to deal with. And there have been, multiple books written by about this. One of my favorite books is called "Do No Harm" by a neurosurgeon in Britain, who kind of talks about, all the surgeries he's done in the past and his experiences with treating patients, and learning from other mentors, preparing well for cases. I think that helps you as well as a surgeon avoid complications.
Okay, thank you. Yeah, have been getting into reading more books lately, like educational books. I did read this book by a neurosurgeon. It was called Into the Magic Shop. It was actually really nice, and it kind of talked about experience getting through surgery. So I'll definitely look into that book. What was the name of it again?
It's called "Do No
Do No
Harm" by
Harm.
Henry Marsh. Yeah, I think
And
somebody in the chat has read it. Yeah, there are
okay.
lots of books about neurosurgeons, but yeah, that's a good book.
Okay.
Yeah,
And I'm gonna wrap it up. One more question.
sure.
Good. Okay. So what challenges sort of, and this can go through any extent, through like any topic. What challenges have you been facing in the last 2 years and just the healthcare field in general from your perspective? And like, has it been getting any better the last few months? And with like vaccines and
Yeah,
sort of the new variant. And so what is your
sure.
perspective on how the next few months and years are going to look and like what you would say to someone who really doesn't know what the hospital is like right now?
Yeah, this is a really good question. Commend you actually for this very thoughtful questions coming from a high school student. Um, I think the most important thing, obviously, in the last 2 years has been COVID. And that's kind of
Mhm,
taken over healthcare in general. And this has affected every aspect of healthcare, even surgeries. And so, a few months ago, we had no beds available in the hospital where I work. And that was because all the critical beds were taken up by patients with COVID. And, that starts to affect not just, the fact that there's a risk of everybody, getting infected, your family getting an infection, but also patients who have medical problems. So, I saw a patient with a medical with a brain tumor, with a metastasis, that a brain tumor that spread to the brain, who needed surgery right away. But there were no beds available in the hospital, so I couldn't do the surgery because there were no beds. And
mhm,
so that's one thing that you don't you may not necessarily focus on, because the news is talking about just infection itself, but patients who have other
mhm,
medical problems, if they have a stroke, if they have a heart attack, if there are no hospital beds because all the hospitals beds are filled with COVID, then those
mhm,
patients are also suffering. And so this is why it's critical for everyone to get vaccinated. If you have age to get vaccinated, I know now it's been opened up to kids greater than 12, and
mhm,
with new variant that comes in, then obviously this virus is going to continue to mutate. So this will be something that's probably going to be with us for some time, and
mhm,
other boosters that we'll have to get. So I just encourage everybody who hasn't gotten vaccinated to go get vaccinated. If you're up for a booster, go get a booster shot.
mhm,
Because that not only keeps you safe, it keeps your family members safe, but also people with other medical problems. So we can provide the medical care that those patients need uh,
mhm,
by not overwhelming the hospitals and hospital beds, and also hospital workers, the nurses who are working in the hospital, doing double shifts because people are getting burnt out by treating,
mhm,
COVID patients, and you're constantly seeing patients who are still by this time not vaccinated. And like I was saying earlier, that patient who needed the urgent brain tumor got his vaccine, but
mhm,
he felt like I can have a hospital bed even though I did the right thing. I got my vaccine, but I ended up with this brain tumor. Whereas there are patients who didn't get their vaccine, and those patients are getting hospital bed. So there's a little bit of a ethical, discussion with that, like, we're prioritizing people who are not sort of doing the right thing over people who are actually doing the right thing. So
Mm-hmm.
that's a challenge that we have to deal with. Obviously, we are doctors. We have to treat everybody who comes in who has a life-threatening issue. But at the
Mm-hmm.
same time, we have to do the right thing by protecting ourselves and doing everything we can to prevent the virus from spreading. You know,
Mm-hmm.
that goes for wearing your masks as well if you're not vaccinated. Washing hands and taking the necessary precautions.
Mm-hmm. Yeah, I completely agree. And especially, going to the hospital every day. I mean, at first it was probably very scary, and even now, like, um, because you're coming home back to your family if you have family and
Right.
things like that. So yeah. Okay.
Yeah.
Thank you so much for talking to us about that. And I also encourage everyone to get vaccinated. Listen to Dr. Fauci.
Yes.
Um, Yes. So thank you so much for coming in. My screen is a bit lagging right now. I can't really see the chat or anything, but it's a little bit frozen. But I really want to say thank you so much for coming in and talking to us. I recently actually shadowed like a surgery at one of my hospitals with this program that our school was offering. And I was like interested in kind of like the OR and like I found the whole experience like really exciting. So this talk has really helped me, see like, okay, what am I interested in? And I think we all gained so much knowledge by you talking about all the cases and very detailed. You have very detailed explanations. So thank you
Thank you.
so much.
Oh, my pleasure. Yeah, and if there are other questions, I think there are a few other questions in the chat. You can send me an email or something. I can try to answer them and send it out to people.
Okay, definitely, yes. Send you an email. I think I'll get that with one of our presidents. And if you like, it would be great if you could put in your contact information in the chat.
Yeah,
Um,
so I'll do that right now. So actually, you guys are probably not on LinkedIn. I'll just put my email address. How about that?
okay. The MedicaZone does have a LinkedIn, so I can forward that to
Oh, okay.
Jason, who handles that.
Yeah, you can do that. You can send everybody my LinkedIn contact so they can contact me through LinkedIn. Okay. All right.
Okay.
You
Well,
guys have a good rest of your day. Okay.
yes, you too. Bye. I really hope you come in again.
Sure.
Bye.
Anytime. All right. Bye.